Welcome to our presentation on dismantling implicit bias to promote optimal health outcomes. And I'd also like to take an opportunity to wish you all Nurse Practitioner Week 2020. We're now celebrating that. I'm Dr. Diane John, one of the presenters. I'm an FNP and faculty at Frontier Nursing University.
And I'm Dr. Katheryn Arterberry. I am an FNP as well, and I am the clinical director of the Family Nurse Practitioner Program at FNU.
And I'm Dr. Lisa Chappell, also a family nurse practitioner, and I'm the chair for the Department of Family Nursing at Frontier Nursing University.
So the objective for today's presentation are to define implicit bias, to describe who was affected by implicit bias, to identify health disparities related to implicit bias, and to discuss approaches to dismantling implicit biases. And we, when I say we, myself, Dr. Chappell, and Dr. Arterberry, are very happy that you're here today to join us on this journey in investigating and learning a little bit more about implicit bias. So there is a plethora of research being done, or that has been done, concerning implicit bias. Implicit bias is real. Bias is a preference for and a prejudice against a person or a group of individuals. There are three characteristics that make a bias implicit. One is that implicit bias operates at the subconscious level. It's outside of our own conscious awareness, which means that we don't even know we have them. A second characteristic is that implicit bias runs contrary to our stated beliefs about who we are as human beings. You can be a healthcare provider and say that you are deeply committed to the best outcomes for all of your clients. Yet, there are some populations who may not receive the same level of healthcare treatment as other populations. The third characteristic is that implicit bias is triggered through rapid and automatic mental associations that we make between people, ideas, and objects, and the attitudes and stereotypes that we hold about people. And here is an example. As we explored the history of implicit bias, we learned a little bit about the developers of this particular concept. And so just listen to this. Mahzarin Banaji and Anthony Greenwald, the two who developed the theory of implicit bias, came upon this observation in the late 1990s. And so what happened is that Mahzarin Banaji and her colleague took a moment to realize how their decisions are guided by forces that they were not even aware of. So they did a simple experiment. Mahzarin was asked to associate dark faces with negative words. She had to use a computer key whenever she saw a dark face or a negative word, like devil or bomb or war. And likewise, there was another key on the keyboard that she had to strike whenever she saw a white face or a good word, a word like love, peace, or joy. And she was able to do this very easily. However, when the test was switched, or the pairing was switched, which meant that she had to identify black faces with good things and white faces with bad things, her fingers froze and she wasn't able to do it. She was definitely very surprised by her response. What she said was, in order to just think about where implicit bias comes from, it's a good idea to think about it as a combination of two things. First, our brains, and the other is our cultural orientation, or our past experiences. So implicit bias, if you think about it again, it's those associations outside of our conscious awareness that lead to a negative evaluation. And you did hear me say about those positive pieces, but it definitely impacts people negatively when there is a negative evaluation or a negative association on the bias based on irrelevant characteristics such as race or gender. So here I'll play a little video that explains a little bit more of what is implicit bias.
Implicit bias exists when we unconsciously hold attitudes towards others or associate stereotypes with them. For example, we often harbor negative stereotypes about others without consciously realizing that we do so. Implicit bias, which is also called unconscious bias or implicit social cognition, is a prejudice that is deep-seated within the brain, below the conscious level. Studies have demonstrated implicit bias against racial groups, genders, LGBTQ, and other marginalized groups. We may even be prejudiced against our own group, although we tend to favor our in-group with positive stereotypes and disfavor out-groups with negative stereotypes.
The immediate feeling you get or the immediate thoughts you have about a person, an assumption you feel, just anything you feel really stems somewhere from an experience you've had or your upbringing.
It depends on the region you're from, the country you're from, the background you grew up in. That shapes the person's unconscious bias.
I think sometimes you don't even realize it, but your own actions, maybe the way you treat others as opposed to treating others that look like you or that act like you or that are your friends.
Implicit bias often runs counter to people's conscious, expressed beliefs. Few physicians espouse racially discriminatory views, and yet doctors tend to recommend less pain medication for black patients than for white patients with the identical injury. In other words, people can be explicitly unbiased, yet implicitly biased, according to psychologist Daniel Kelly and colleagues.
One of my closest friends since high school, we've worked on a lot of projects together, we've been in a lot of classes together. Sometimes we'd be working together in a group project, for example, and she would say stuff like, oh, you're good at math, you're good at science, here, you can take this part of the project or something. I don't hold it against her or anything, and she doesn't mean any harm by it, but obviously there's that implicit sort of bias or stereotype that Asians are better at math and science.
So you can see some really good examples of implicit bias, both negative associations and positive associations that can lead to prejudice and inequality, and that are definitely detrimental to clients in the healthcare environment. So who is affected? We're all affected by implicit bias, and we all have them. Healthcare providers, healthcare workers, our clients, communities, and populations. Dr. Chappell, is there something that you'd like to share about who was affected by implicit bias?
Thank you, Dr. John. Yes, I would like to share and recognize one of the populations who do suffer implicit bias are inmates or prisoners. I did work in correctional medicine prior to my time at Frontier and found there was a great deal of implicit bias in the delivery of care to the inmates that I worked with.
And I believe that Dr. Arterberry had an experience that she also wanted to share.
I agree with Dr. Chappell that certain populations are definitely at a greater risk to be affected by implicit bias. I actually do my faculty practice work in a free clinic for the underserved and for those great population of Spanish-speaking clients as well. And I have on multiple occasions heard from those very clients about how they have perceived implicit bias or bias impacting their healthcare. And so it's good to be able to have that place where they can come and not experience that same level of implicit bias as they did in the general population.
Thank you for sharing. So the literature tells us that healthcare professionals exhibit the same levels of implicit bias as the general population. You know, as healthcare professionals, clinicians, healthcare workers, we all take an oath to do no harm. And we all explicitly will state that we want the best for our clients. Yes, yet there are groups of individuals who are at a greater disadvantage than other populations. And a few of them are listed here. Our LGBTQ plus community, men, women, those with mental health concerns or conditions. Dr. Arterberry just shared individuals where English is a second language. The elderly, of course, we've talked a little bit about race and ethnicity, immigrants, and our children. So everyone is impacted by implicit bias.
Implicit bias is a contributing factor to health disparity. It can influence the development of and changes to health policy that are needed to improve care to minority populations. And without a more diverse and inclusive health policy, the results will be poor health quality, less equality in care, and a poor public health outcome. A recent example of a change in policy was a law that was passed in New York State. The new law passed was called Shannon's Law. It was named in honor of a young woman, Shannon Sumato, who was diagnosed with breast cancer at age 28 while she was pregnant. The new law requires insurance coverage by companies for screening mammograms starting at the age of 35. The American Cancer Society tells us that in Black women less than 55 years old get breast cancer 2 times the rate of white women and have 3 times the rate of death from breast cancer than white women. Screening mammograms should be covered in a more culturally congruent manner. Implicit bias can also impact the use of diagnostics in minority populations, such as the decreased use of diagnostic imagery like CAT scans and MRIs, and consider the use of racial correction in clinical algorithms. Dr. John and Dr. Arterberry, this was something that I learned new in preparing for this presentation, was the existence of racial corrections in clinical algorithms. Here's an example of how it would work. I read about a patient named Eli who was a Black male with nephropathy, which is progressing to the need for a kidney transplant. The GFR, glomerular filtration rate, which is a measure of kidney function, sets the level of 20 to determine the need of a kidney transplant for the patient. Eli's GFR results were actually over 20 because it was adjusted by 4 points because he was Black. So points were added to his test results that put him out of the range of being able to get on the list to receive a kidney. But this is an example of race adjustment or correction. But Eli's nephrologist did not stop there. She did a 24-hour urine and blood test, which have no racial adjustment factor. His results in these tests was a 20, and he is now nearing the top of a transplant list. So when I read about these racial adjustments, I wondered, what's the scientific basis on which they're established? How invasive is this in diagnostic testing? And is it a current, equal, fair way to interpret test results? Studies have also shown a decreased use of thrombolytics in Black patients with chest pain who are having an MI. And there's a decreased referral for screening mammograms based on breast cancer statistics for Black women, as we talked about with the new Shannon's Law in New York. Misdiagnosis related to implicit bias does occur. Rose, age 37, believes that her age, gender, and possible same-sex spouse influenced an emergency department physician's treatment. She presented to the ER with stabbing pain in the back of her head, left eye drooping, right side numbness, and inability to swallow and difficult walking. She was seen in the emergency room, tests were ordered, and she was sent home and told by the emergency room physician that she was not having a CVA. 2 days later, her family took her to a different hospital where within 2 hours she was diagnosed as having had a CVA. Implicit bias can influence pain management. Studies have found that cancer pain in Black patients can be underdiagnosed, underestimated, and undertreated. Also, just in general in pain management, minorities and children receive suboptimal pain management. The expression of pain can be influenced by race or gender and does have cultural influences. Patients may feel they need to be more stoic. They may fear being labeled a hypochondriac. They felt they must be strong, and they're so busy caring for others that they cannot care for themselves. Other studies have found decreased medication use in Black patients with hypertension, diabetes, and high cholesterol. Black patients have lower survival rates than white patients who have early stage non-small cell lung cancer. Surgical resection is the optimal treatment. However, Black patients are less likely to receive that surgical treatment when they've been diagnosed with this type of lung cancer. White patients are more likely to receive invasive cardiac procedures such as cardiac cath or coronary artery bypass than Black patients. Recently, a woman had abdominal surgery. The surgeon stopped her pain medication after 2 days. She developed excruciating pain during the night. The next morning, the surgeon told her that she was being too sensitive and discharged her home. The patient returned within 24 hours and was diagnosed with peritonitis, which then developed sepsis. Do you think there was implicit bias in the care of this woman? Dr. John, what do you think?
It sounds that way, Dr. Chappell. I mean, would they have treated other clients the same?
Well, I wondered if she would have been treated different if she had been a man. And we don't know her other factors. Was she white or African American? How old was she? But there are a lot of, this kind of makes you think that there was implicit bias here. You know, communication between the patient and the provider is essential for effective disease management. In patients with cancer, if they do not have good communication with their provider, if they have poor communication with their oncologist, it results in a decreased trust in the oncologist's ability to provide care. And then lower levels of interpersonal care between a patient and his or her provider results in decreased trust in that care that the provider is giving them. Dr. John, would you add anything to that?
I would, Dr. Chappell. You know, we've all read an abundance of literature that talks about implicit bias as it relates to pain management and disease management. And you talked a bit about the clients with cancer. And I went a little bit further. And so there was a study that showed that providers with high levels of implicit bias were less supportive of, and they spent less time with their patients compared to providers with lower levels of implicit bias. And our patients pick up on these findings and these attitudes and these observations. They actually view those providers with high levels of implicit bias as less patient-centered than the physicians or providers with lower levels of implicit bias. The patients also report having more difficulty remembering what they were told by their providers. They had less confidence in their treatment plans, and they thought that it would be more difficult to follow the recommended treatments.
Thank you, Dr. John. Implicit bias can be seen as discrimination by the healthcare provider, the LGBTQ plus population, when they recognize discrimination, will delay seeking medical attention, will use the emergency department more frequently, and neglect routine checkups. A study found that discrimination toward indigenous people contribute to poor mental, behavioral, and physical health. American Indians have an increased risk of PTSD and alcohol dependency. And there's a wide racial and ethnic gap in maternal mortality between Black women and white women. A white woman's maternal mortality rate is 14.7 deaths per 100,000 live births, while Black women have a maternal mortality rate of 37.1 deaths per 100,000 live births. Some things to consider as to why there is such a discrepancy in maternal mortality between races. Racial discrimination as chronic stress. What does this have not only on the health of a pregnant woman, but on those who are discriminated against over their lifetime? Health disparities may manifest during pregnancy through the immune system, the neuroendocrine system, and the cardiovascular system. I'd like to take a minute and just read to you about Serena Williams, the tennis star, and her health event that happened with her with the birth of his child. She found herself in a life-threatening situation after giving birth to her daughter by emergency C-section. She had a history of blood clots and had stopped using blood thinners before the delivery. When she started experiencing shortness of breath after the delivery, she told her healthcare providers that she was likely having a pulmonary emboli. The medical staff insisted that she was confused due to pain medication. Serena persisted in letting them know that she was in trouble. They did do a CAT scan, and it confirmed her suspicions that she did have a pulmonary emboli. So here's someone that is very famous, well known, and was she the recipient of implicit bias?
Dr. Chappell, there are so many of those cases in the literature, unfortunately. I recently read about one where a young woman was in her third trimester, came in through the ED, I believe, and reported that she was leaking fluid, but no blood. And the emphasis was on whether she was a substance user, whether the father was present, and some other things that may be insignificant at that time. The outcome was detrimental. She lost her unborn child. So many of those examples exist in the literature.
You're right, Dr. John, they do. It's almost overwhelming once you really start getting deeper into the literature. Implicit bias can also influence the delivery of psychiatric care, such as improper medication prescribing. The healthcare provider may believe that Black patients are less likely to comply with treatment and may prescribe differently based on race. Black patients are disproportionately diagnosed with schizophrenia when compared with white patients, but Black patients have an underdiagnosis of mood disorders. Black patients may have less access to care, to psychiatric care, and when they do receive it, it may be poor quality care. Implicit bias can impact emergency department care. Studies have shown that there is less pain management for minorities. Also, they're less likely to be admitted to the hospital when it is needed. For example, Rose, the 37-year-old with the CVA, was not admitted. She was sent home. Decreased diagnostic testing. One study reported decreased testing in children with GI symptoms and disorder. Dr. John identified children as recipient of implicit bias. Another group that is concerning is patients with sickle cell disease. There's a lack of knowledge for current management guidelines, particularly management of pain in the care of patients with in sickle cell crisis. Dr. Arterberry, would you add anything to that?
I really would like to, Dr. Chappell, because as we got into the literature and started looking at these implicit bias and how it relates to health disparities, I was reminded that each of these instances that we read about are real live people. And having experienced it myself, I could tell a quick story about my father. We took him to the emergency room for a low blood pressure. They put a blood pressure cuff on him. And soon after that, in a shared room with a curtain, they brought in an elderly Black female who I could hear what they were saying. It was a curtain. And who reported that she was feeling unwell, that she had a history of heart disease, and she just didn't feel good that day and had thrown up a little bit and, just did not feel herself. And from the symptoms that she was stating out loud, I whispered to my mother, I said, she sounds like she's having a heart attack. Well, the nurse came in and patted her on the hand and gave her some anti-nausea medicine and left. And by the time they got back, well, they didn't come back. The woman went into an acute MI. The daughter called out for the staff and they were kind of slow moving. I'm being a nursing instructor in the area, went out and said, we need help in here now. And that generated them coming. But I just wonder if she had been a white female or a white male, if they would have recognized her symptoms better, done more diagnostics to catch that sooner. And unfortunately, this elderly lady died from a acute MI. And so when we talk about this implicit bias, and these are good people, these are good providers, these are people who went into their to nursing and to medicine to help people, but that they're missing these things simply because of a bias that they're not even aware that they have. It's very important that we start to recognize this.
I agree, Dr. Arterberry, and you really made me think about the truth that we all have implicit biases. Each one of us do. But for those of us in healthcare, the recognition and the working through our implicit bias is so important to prevent patient harm or the death of a patient. So it is extremely important. So if we can decrease implicit bias, we can improve health outcomes. And that improvement would be seen as earlier diagnosis of patients and their problems, improved health as an outcome for our patients, improved management of care, where we remove implicit bias in our decision making for providing care, and then increased trust between the healthcare provider and the patients, which the patients are due this.
As we develop this presentation, it was like taking a huge step as we developed this presentation, going from what is implicit bias to how it impacts health disparities. And I put on this slide, you've taken the first step, but it's really we've taken the first step because we went on this journey with you. Because now we do recognize that implicit bias exists, and it exists in all of us. Every one of us has some measure of implicit bias. Even good people, even very good people have implicit bias. And that existence of that bias will negatively impact healthcare and healthcare outcomes. So we have to do something about it. That's right, Dr. John, we can go. We have to do something about it. And so what are our next steps? Because we don't just want to recognize that bias exists or that it impacts healthcare, but we want to start to work to dismantle implicit bias in ourselves and in our colleagues And so we came up with 3 strategies. These are not meant to be comprehensive, but we came up with 3 strategies to reduce implicit bias and its impact. The first one is that we have to identify our own personal bias, and we have to individualize when we deal with our patients rather than categorize. And then we have to initiate action. So the first strategy that we're going to talk about today in order to dismantle implicit bias is identification. And we're going to do that through, and when we look at identifying our personal biases, we're going to do that through identification, introspection, and reflection. Now, as we have talked, some of you may have said, whoa, hold on, wait a minute. I have seen implicit bias in my coworkers, but that is just not how I operate. If this statement is what immediately came to your mind, you might be suffering from what is called the implicit bias blind spot. And that terminology was coined by Banaji and Greenwald that Dr. John spoke about earlier. And I submit to you that as good as you are, as wonderful as we think each other are, everyone has implicit bias or unconscious bias. So how do you identify? What are your implicit biases? The Harvard Implicit Association Test, Dr. John gave a brief overview of what that is, to associate good with white and bad with Black people, and then to make the switch and see how fast you were able to do it and how it froze that investigator's hand. She just couldn't do it. And that's because in our minds, there are associations that have been built up over time, connections made over time that's very difficult to overcome without you even knowing that they're there. If I say the word peanut butter, the vast majority of us would immediately think of jelly. Why? Because peanut butter and jelly, we've been conditioned that that goes together and makes a good lunch sandwich. Peanut butter goes with jelly. And the same way these biases have been placed into our brains so that it automatically happens without you even thinking about it. So I would challenge you to go to that Harvard website and take the implicit association test. They have them not just for Black and white or race, or they have them for gender, they have them for age, they have them all different types of things, religions. So we can really identify where our biases lie. And that's very important. Before we ever go into a patient's room, that's, I believe, is where we should start. What do you think, Dr. Chappell?
Well, I think that is a real good beginning, Dr. Arterberry. I was thinking about in clinic when you're seeing patients, you pick up that chart and you look at the patient's gender, you look at their age, and you look at their chief complaint. And before you step in that door, recognize your implicit bias before you start your interaction with the patient. Is there something about their gender or their race or their age that may impact your care if you hold implicit bias for those areas?
That is so true, because if you can recognize them before you go into that room, you can set them aside so that you can care for that patient using the best evidence. And during the visit, I think that introspection comes into place. Introspection is the examination or the observation of your own mental or emotional process. It's self-analysis, it's soul searching or heart searching. Have you ever had anyone to reveal to you in conversation something about yourself that you think is far off, far-fetched, doesn't sound a bit like you, but once you really soul search, once you really dug deep, you found out that it was really right on target? Almost like a tale in poker. I'm not a big poker player, but there's sometimes unconscious actions that you do to tip off other players as to what your hand looks like, and you never even knew it. And so that's the way unconscious bias works. So in order to dismantle your implicit bias, you really have to go through this process of soul searching. In short, just kind of be aware of your actions. Are you allowing the patient time to ask questions? Are you listening? Because with implicit bias, that is decreased. Your listening is diminished. You're short. You take less time with the patient. Are you giving adequate answers? Is the care you are providing evidence-based? Are you welcoming, or are you stressed? There are reports that says that when a provider is more stressed, the implicit bias takes over more. You fall back into what your mind tells you. In other words, just be mindful when you're in the room with the patient. And then after your visit, reflection is a form of thoughtful consideration with the aim of achieving some better understanding or new learning. You might remember John Dewey famously said that we do not learn from experience, we learn from reflecting on experience. So reflection allows you to make sense of an experience for future benefits. So maybe I didn't get it right with this patient, but I'm going to work on it and get it right with the next patient. It allows you to decrease, in the instance of decreasing the effect of implicit bias has on our patient outcomes, it benefits us to go through this reflective process. It means taking time out of your busy day, your busy schedule, your busy week to critically look at your actions through the lens of implicit bias. Margaret Wheatley said, without reflection, we go blindly on our way, creating more unintended consequences and failing to achieve anything useful. Let's really hope that we don't stay there. That's the purpose of this presentation. Or if you need a more recent and less esoteric voice to validate this process, consider Michael Jackson. And he said, I'm starting with the man in the mirror. I'm asking him to change his ways. And no message could have been clearer. If you want to make the world a better place, take a look at yourself and then make a change. That's reflection and the purpose and intent and aim of reflection. Dr. John, I think you had something to add to that.
Yes, thank you, Dr. Arterberry. So when I think about reflection, and I see your questions here on the slide, what have I done well and where can I improve? And you mentioned a couple of times that healthcare providers, I'll say it, we're really good people. We want our patients to have the very best outcome. However, at the end of the day, when we reflect and look back at what was done well and where can we improve, we also have to look at our office staff and our office environment. There's something called the Lupus Initiative, and this was developed by Georgetown University's National Center for Cultural Competence. And they use a case during one of their trainings. There's a gentleman, Michael Thompson, who interacts initially with the office staff. The office staffs make an assumption that he has no insurance, that he has not seen a provider because of his own neglect or self-neglect, which is very far from the truth. So when we're reflecting as providers on what we can do well or what we've done well, we also need to look at what's happening in our offices. What are our personnel doing? How are they interacting? Do they have the adequate training to be able to identify their own implicit biases and to make sure that we are improving the experience for all of our clients?
That's a great point, and it's definitely a process. It's a process that we have to continue on and on to improve. So let's move on to strategy 2. And again, these are not really comprehensive. There are a lot of other things you can do, but we wanted to bring out some things that we thought would benefit us. The next strategy in how to dismantle implicit bias is individualization versus categorization. So the biggest part of that is stereotyping. We have to deal with the stereotype and refrain from stereotyping. We can fall into it so easily. Stereotyping is an unfair and untrue belief that represents an oversimplification a prejudiced attitude or an uncritical judgment. It's usually fixed. It's an overgeneralized belief that you take from one person and put across to an entire particular group or class of people. To prevent stereotyping, you have to be aware of your own biases. You have to avoid imposing your beliefs and values on members of another culture. So you have to develop cultural knowledge and cultural appreciation for other people. There's also such thing as counter stereotyping measures. And that's where you really expose yourself to opposites of what the stereotype is. So that if you had a screensaver and you put you had a gender bias, then you put a construction worker with a hard hat on breastfeeding her newborn infant. That counters the stereotype of what you think a construction worker should look like or be like, or either have a photo up that shows a big burly black man gently holding his newborn, nurturing his newborn son. And so that counters that stereotype that black men are violent. So you have to expose yourself and really make conscious effort to diminish that stereotyping. The other thing is to individualize. We need to show compassion, commit to compassion. And compassion, the important thing about compassion is that it allows ourselves not only to be moved by suffering and experiencing, but be motivated to help alleviate and prevent it. That is the important part. So I wanted to talk about a few qualities of compassion, along with wisdom, patience, kindness. We can all be kind, perseverance, warmth, and resolve. And as a means of getting us started on exercising compassion. So the first part of that is to put yourself in someone else's shoes. I guarantee you will be able to find commonalities that can help us dismantle implicit bias. Move beyond your self-referencing. Be willing to grow and stretch beyond your personal and past experience. Because some of us feel like we are experts on certain things because we've experienced it, but we're only one person. So we have to grow beyond our experience and look at the world as a whole. And I mentioned this a minute ago because it's so important to practice kindness. You don't have to be a people pleaser to practice kindness. But when we talked about going into the room with a patient, a lot of that, what shows up as implicit bias will be overcome if you would just be kind in that room. Relax your judgments. You gotta be willing to let some stuff go. And my granddaughter would say, like Queen Elsa in Frozen, let it go. I'm on the songs today, but let it go. Be a generous listener, heal your own trauma, hurt people, and practice presence, mindfulness, be there. That is a big part of compassion. And empathy kind of goes right along with that compassion. So we want to enhance our empathy. And that really is the first part of compassion. That is the ability to understand and share the feelings of another. So I want to present to you that there's cognitive empathy. It's just basically being able to put yourself in someone else's place and see their perspective. How far would that take us? Emotional empathy is when you literally feel the other person's emotions alongside of them. And like you just catch the emotions. If you go to a funeral and you see a grieving mother and you just feel that with her. And that is an important part of empathy. But we have to know how to manage that in the healthcare field in order for us to be effective. But the one I really want you to hear is the compassionate. You remember we just talked about compassion? It's compassionate empathy. It's to understand and sympathize with what they're going through and crucially either take or help them take action to resolve the problem. That is where compassionate empathy comes in, and it is really the most appropriate. Another way to individualize versus categorize is to increase social contact, having cultural encounters. Expose yourself to face-to-face encounters in different environments with different people from different cultures, different classes. If everyone you affiliate with looks like you, is of the same socioeconomic status as you, that is not the way to dismantle implicit bias. Broaden your friends. I'm not saying just call Dr. Chappell because you need a white friend, or call Dr. John because you need a black friend, but we do need to increase the interaction we have with people. America is a great country with all different kinds of races, ethnicities, religions, genders, and so we need to open ourselves up to that. And then the last one on this list is to collaborate. And I think that nurse practitioners do that really well as far as decreasing the power differential between you and your patient. We need to work jointly together to produce or create the result that it is that we want to do. So by creating a shared human identity, by seeing more of our likenesses than our differences between patient and provider, if we do the work that we just talked about on this slide, we'll be connecting with patients in a robust, real perspective, and it will allow them to be cared for as a three-dimensional being and not just a one-dimensional person that we can step over. So it would allow us to treat individuals with less bias. I know we stayed on that slide a long time, but it has some important things that I wanted to say to hear on that. Our third strategy is to just do it. You got to initiate action. You cannot do the same things tomorrow that you did before you listened to this presentation today. You have to commit to do the work. You have to understand that this is a process and it works over time. It's going to take effort, but commit to be purposeful and plan with intentionality. It's not a linear process, so allow yourself some grace. So when we talk about compassion, allow yourself some self-compassion as well. You have to be willing to champion change. You may be the lone voice at first because not everybody wants to look at the man in the mirror, but we have to champion change and understand that it only comes after identification, individualization has been worked through. It can be said that the work is an individual work, and it is. Each of us has our own individual work to do, but it does need to spread from our own individual work to others. So we need to champion that thought as well. And then we need to decrease the impact of implicit bias by implementing all of the above mentioned actions. It's not a matter of doing a checklist to check them off, but where you find that you need work, be willing to do that work. And I think that we can decrease the impact of implicit bias on health outcomes. We must decrease the impact of implicit bias on health outcomes.
Thank you, Dr. Arterberry. Just do it, and you're right. We must decrease the impact of implicit bias on health outcomes. So as we close today's presentation, the three of us, invite you to join us in taking the pledge to dismantle implicit bias. I'm Dr. Diane John, a family nurse practitioner and full-time faculty at Frontier Nursing University, and I pledge to dismantle my implicit biases.
My name is Katheryn Arterberry, and I'm a family nurse practitioner, and I'm the clinical director at Frontier Nursing University, and I pledge to dismantle my implicit biases.
I'm Dr. Lisa Chappell, family nurse practitioner, and the chair for Department of Family Nursing at Frontier Nursing University, and I pledge to dismantle my implicit biases.
Please join our colleagues as they pledge to dismantle their
Hi,
own
my name is
implicit
Dr. Kara
biases.
Jefferson, and I'm a family nurse practitioner. I am course coordinator of PC 742, and I'm also course faculty in the other DNP clinical courses. I pledge to dismantle my implicit biases.
I pledge to dismantle my implicit biases.
I pledge to dismantle my implicit bias.
Hello, I'm Stephanie Boyd, Director of Clinical Outreach and Placement at Frontier Nursing University, and I pledge to dismantle my implicit bias.
Hello, my name is Dr. Kristen Gianellos, DNP Clinical Faculty here at Frontier. I'm an adult and women's health nurse practitioner, and I pledge to dismantle my implicit bias.
Hi, my name is Heidi Loomis. I'm a family nurse practitioner and midwife and regional clinical faculty at Frontier, and I pledge to dismantle my own implicit biases.
I pledge to dismantle my implicit bias.
Hi, I'm Joanne, and I pledge to dismantle my implicit bias.
Hello, this is Jane Houston, the Director of the DNP program at Frontier Nursing University. I pledge to dismantle my implicit bias.
Hi, I'm Kim Barona, and I'm a nurse midwife, and I pledge to dismantle implicit bias.
I'm Tanya Nicholson, Department Chair of Midwifery and Women's Health, and I pledge to dismantle my implicit bias.
These are our references. And we invite you to join us in celebrating 50 years of the Family Nurse Practitioner Program at Frontier Nursing University.
Yes, and happy Nurse Practitioner Week to you all.
Happy Nurse Practitioner Week, everyone, and congratulations, Frontier Nursing University, on the 50th anniversary of the Family Nurse Practitioner Program.
And that concludes our presentation.